So good morning, ladies and gentlemen. It is our pleasure to welcome you to this last session, the highlights. I would like first to congratulate Michel Boehm, who is a Congress Program Committee Chair, who has been designing this fantastic program together with his peers, and I think it's fair to say that publicly. I think he will now call the awardees for 2012, and I hand over to him.
Thank you very much, ladies and gentlemen, colleagues and friends. It's a great pleasure for me to announce now awardees, in particular young people, people from all parts of the world who have contributed significantly to the high standard research we have heard. First, I come to the Young Investigator Award. We have Challenging Case Reports Awards, in particular from young cardiologists. We have awarded the best abstracts with the highest grading. We have moderated poster and the best posters from the affiliate countries, which were awarded in a separate session for those who are coming from out of Europe. So I would like to announce first the Young Investigator Awards. These were excellent presentation. The winner is Francesco Paneni from Italy. We had three other awardees, runners-up: Akio Monji from Japan, Dr. Kapopara from Germany, Konrad Hötzenecker from Austria. We had Young Investigator Awards in Clinical Science. This is Darren Mailot from France, Hel Söböhm from Denmark, Isabel Johansen from Sweden, and Barna Chabu from Hungary. Three runners-up, and the winner is Darren Mailot from France. We have Young Investigator Awards in Coronary Pathophysiology and Microcirculation. These were awarded by the working group. The first is Fabio Mangiacapra from Italy. He's the winner. And the runners-up are Kensuke Nishijima from Japan, Antonios Karanassos from Greece, and Giovanni Luigi Di Maria from Italy. We have Young Investigators Awards for Clinical Science. The winner is Mattis Flyfholm Rand from Denmark, Aziza Assimi from Denmark, and Salvatore Brugaletta from Spain. The winner is Dr. Rand from Denmark. We have Young Investigators Awards for Thrombosis, and again this was chosen by the working group. The winner is Erik Walter Holi from Switzerland. And we have three runners-up: Bjering Ölesen from Denmark, and Baytullah Çakal from Turkey, and Katharina Hess from Germany. We have Challenging Case Reports. The winner is Amar Kilu from the United States of America. We have three runners-up: Shrenik Doshi from India, Catarina Ferreira from Portugal, and Federico Landetta from Argentina. Then we have affiliated countries, which is a new format we have generated in a separate lecture room, and I would like to mention them all. There is no first winner, they are all winners, and you can see we have people from India, Australia, Taiwan, Republic of Korea, Canada, and Japan. And I would like to thank you all that you have taken the hardship of traveling so far to come to Munich to this Congress, and I hope you all enjoyed it. We have winners of moderated posters. The CPC, the Congress Program Committee, selected the best posters. They were chosen to be moderated in an oral kind of session, and these were the winners. Again, from Netherlands, Germany, UK, United States of America, Belgium, Finland, Sweden, and Japan. Last not least, we have selected out of 4,609 contributions the highest scored posters. So those who are selected as posters, you can see here. Again, you can see a wide range of countries contributing to this high quality scientific work from Germany, Spain, Argentina, Japan, France, Italy, Netherlands, United States of America, Sweden, and United Kingdom, as well as Taiwan. I would also like to thank, on behalf of the ESC board, the scientific program committee and the judges, all the winners, in particular from those countries outside Europe, for their excellent work. And here you can see the winners and the young people who've done such outstanding research. I wish you a nice highlight session and a safe trip back home.
Thank you and congratulations to all these colleagues. The first report will be made by Stefan Engelhardt from München on basic science.
Okay. So, dear colleagues, from the huge program of this excellent meeting, I've chosen 4 exemplary studies from 4 different areas of research. The first study is on gene therapy for recessive catecholaminergic polymorphic ventricular tachycardia, short CPVT. CPVT is typically caused by mutations in calcium-handling proteins, namely the ryanodine receptor, and by calsequestrin, the latter being autosomal recessive. And this is the reason why animal models deficient in calsequestrin represent a good model for the disease. The aim of the study was to employ adeno-associated AAV-mediated gene transfer of wild-type calsequestrin as a therapy for CPVT. This virus also encodes for a green fluorescent protein, and as you can see at the upper right hand, when the authors isolate myocytes from these treated hearts, more than 50% of the myocytes are green, indicating efficient gene transfer. And when they now assay for calsequestrin expression, you can see here marked with a blue arrow that gene therapy with AAV led to restoration of calsequestrin levels. So what is now the functional impact of calsequestrin gene therapy? On the left-hand side, you see an ECG recording from the CPVT model under control conditions and in the lower tracings after challenge with epinephrine. Epinephrine induced profound arrhythmia in all of the untreated mice, but only in 1 out of 10 from the AAV-treated mice. So, in summary, loss of calsequestrin causes CPVT in humans and in mice. AAV calsequestrin gene therapy can effectively restore calsequestrin in vivo, and this cured inherited arrhythmia in calsequestrin deficient animals. So I believe that translation into a human setting appears as a realistic perspective of this experimental study, especially given that the EMA has recently recommended approval for a first gene therapeutic agent in Europe. The second study is entitled G-alpha-13 mediates pressure overload induced cardiac remodeling and heart failure. The colleagues from the Max Planck Institute in Bad Nauheim performed inducible gene deletion of a key signaling protein which has long been ignored in cardiovascular research. And this is a G protein termed G-alpha-13. So as a reminder, G proteins are indispensable for transducing the signals in all of the cells of our body which are received from G protein coupled receptors. And G protein coupled receptors are still the single largest class of targets for drugs on the market. So what happens if one deletes G-alpha-13 in mice? Not much under basal conditions, but if the heart is subjected to pressure overload, and this you hear is depicted here on the left-hand side with TAC. If one subjects those animals to pressure overload, they are protected from developing pathologic hypertrophy, myocardial thickening, and also they are protected from left ventricular dilatation, and they have a clear-cut survival benefit. The authors then set out to determine how G-alpha 13 mediates this detrimental effect in the heart. And as a candidate signaling pathway, they analyzed Rho A signaling. Here on the left-hand side, they suppressed G-alpha-13 and observed an impairment of Rho signaling and also an impairment of nuclear translocation of the relevant downstream transcription factors, namely MRTF-A and SRF. In conclusion, deletion of G-alpha-13 prevents pressure overload cardiac hypertrophy and conferred a long-term survival benefit. The authors convincingly demonstrate that G-alpha-13 in the cardiomyocyte signals through Rho A and SRF, and leading them to the conclusion that G-alpha-13 is a key molecule in hypertrophic signaling. The third study investigates a therapeutic role of angioprotein-like 4 in ischemic stroke. Angioproteins are secreted glycoproteins, and exogenous angioprotein-like 4 has been suggested to inhibit vascular leakage and edema formation, and previously has been shown to reduce infarct size after myocardial infarction. So here a group from the Collège de France in Paris tested the therapeutic efficacy of angioprotein-like 4 administration in ischemic stroke. They treated a mouse model again of stroke, which had a 1-hour ligation of the middle cerebral artery, and treated that animal model at the time of infarct with angioprotein-like 4. The result was a dramatic reduction in infarct size, as you can see on the left-hand side with a staining agent to determine infarct size, and on the right-hand side by MRI imaging. So what is the mechanism underlying this therapeutic benefit? On the left-hand side, you can appreciate that angioprotein-like 4 inhibited vascular leakage and subsequently inhibited edema formation in the ischemic tissue. And the authors suggest that this may be related due to the inhibition of Src kinase activity, a tyrosine kinase also in myocytes and in endothelial cells. So, in summary, the authors propose a rather complex mechanism here depicted on the right-hand side of this picture. In the left half, you see the situation in the healthy vessel. VEGF signals through its receptor, which then interacts with cadherins to seal intracellular clefts in the endothelium. And that induces a vascular seal under healthy conditions. In ischemic stroke, there is activation of Src kinase, which inhibits the sealing mechanism and is the basis of edema formation. Finally, angioprotein-like 4, here depicted in red, inhibits detrimental Src kinase signaling and thereby reduces the vascular leak and ultimately infarct size. So application as a take-home message of angioprotein-like 4, or of course of an agonist, its receptor may work as a therapeutic strategy in ischemic stroke. The last presentation I selected is from the field of cell therapy in cardiovascular disease. The background is that cell-based therapy provided benefits in a number of studies. The objective of that particular study is to test whether factors secreted by the injected cells might cause these effects. The authors applied percutaneous intramyocardial delivery of APOSEC at day 30 after MI. APOSEC stands for secretome of apoptotic white blood cells, which sounds rather complicated, but actually it's rather simple. They take leukocytes in culture, kill them by radiation, take the supernatant and dry that, and apply that then in their preclinical study. Here's the study design. On the right-hand side, the authors studied the setting of reperfused MI in a large animal model in pigs. They performed an MRI after 3 days and invasive functional assessment at day 30. Here they randomized to control treatment or to intramyocardial injection of APOSEC. And then the study was completed another 30 days after randomization and therapy. So here are the results of that trial. Treatment with APOSEC after 1 month led to an increase in ejection fraction, cardiac output, and also to a trend in infarct size reduction, and they observed a significant increase in cardiac index. These findings are in good agreement with intramyocardial viability mapping data here depicted on the right-hand side. So taken together, the authors applied a supernatant from irradiated leukocytes into the myocardium after MI, and this led to a remarkable improvement of left ventricular functions. These findings suggest that a major part of the therapeutic benefit of myocardial cell therapies may be through factors secreted by these cells. So one may call this a cell-less cell therapy. As leukocyte supernatants can be prepared, tested, and stored, they might offer significant clinical benefits. With this study, I would like to conclude and hand over to my colleague, Dr. Schmieder from Erlangen, who's going to talk to us about hypertension. Thank you.
I would like to call Dr. Schmieder from Erlangen to give the summary on hypertension.
Dear chairpersons, dear colleagues, I feel very honored to give you the highlights in the hypertension field of this exciting meeting 2012. I will focus on 4 different topics and will start with the diagnostic part, blood pressure measurement. I will focus on the issue of 24-hour ambulatory blood pressure monitoring and give you some new insight how we can diagnose hypertension more accurately with ambulatory blood pressure monitoring. There are various components, and there is still a discussion ongoing whether nighttime, daytime blood pressure or the dipping pattern is of importance. This Congress had the prospective data of a study lasting 43 months in 10,000 patients with primary hypertension. Admittedly, the event rate was low, but they did a very thorough statistical analysis. And it turned out that by applying various models of the statistical analysis, nocturnal blood pressure was an independent determinant of stroke and atrial fibrillation, and the dipping pattern was not. In this first step of the analysis, they compared nocturnal blood pressure versus dipping pattern, meaning fall of blood pressure by more or less than 10%. Also, night to daytime ratio did not prove to be a significant predictor of stroke and new onset of atrial fibrillation as opposed to the average nocturnal blood pressure. In the same analysis, they focused also on the field whether daytime or nighttime blood pressure is more important as a predictor of incident cardiovascular events. It turned out that again the nighttime systolic blood pressure was the most important predictor of the cardiovascular events they observed as opposed to daytime blood pressure. This study therefore adds power to those studies already published which have shown that nighttime blood pressure might be more important than daytime blood pressure. And I want to remind you that the average normal nighttime blood pressure, according to the guidelines, is below 120/70 milliliter mercury. In another trial, the importance of ambulatory blood pressure monitoring was assessed as a tool to monitor patients during treatment. This has been so far neglected, and therefore I think it is important to stress this cross-section analysis carried out in Germany by approximately 900 family physicians. Now, these physicians include overall 4,708 treated hypertensive patients who all had 24-hour ambulatory blood pressure monitoring at baseline and after 1 year. The task of the physician was to treat blood pressure below 140/90 by pharmacological tools, and then after 1 year to check where they are. Now, these are the results. As you can see here on this figure, office blood pressure or clinical blood pressure below 140/90 was achieved in approximately 50%. But you may also immediately see that those patients who had ambulatory blood pressure monitoring above 130/80 were 32.9%. So clearly, the prevalence of masked hypertension after 1 year of intensifying antihypertensive therapy was approximately 1/3 of all treated patients, or 2/3 of those patients, although they were, according to office blood pressure, well controlled. And this, of course, has clinical implications. They need a further intensifying of antihypertensive therapy. Therefore, it is concluded that effectively controlled, according to office blood pressure, 50%, I think, which is quite good. But according to ambulatory blood pressure monitoring and office blood pressure readings, only 7.6%. This is a call for action. There have been 3 studies which I want to highlight with respect to indicating and identifying prognostic markers in hypertensive patients. First of all, I want also to address the issue of variability in blood pressure, but this time this study focused on visit-to-visit variability, in other words, whether blood pressure is controlled over months and years. There have already been publications 2 years ago, but they relied on antihypertensive trials where blood pressure was the aim of intensifying, of intervening in the various studies. Now, the beauty of this analysis is that they relied on TNT, IDEAL, and CARD trial, meaning 3 trials, where the aim was to lower lipids by statin therapy, and the blood pressure was not touched. In other words, there was no rule whether it should be intensified or not. It was to the discretion of the individual physician how he treats blood pressure, thereby reflecting, I think, more accurately daily life practice. Overall, in this combined analysis, 21,000 patients are included, and they used various parameters of visit-to-visit variability, the standard deviation, the coefficient of variation, and a parameter called VIM, which is a variability parameter which is independent of the mean. But as you can easily see, irrespective what kind of parameter for the variability of the visit-to-visit variability you are choosing, and whether you look at the stroke or coronary events, all 3 variability parameters turned out to be significant. And most important, the treatment effect by statins for reducing risk of stroke and coronary events was not affected or mediated by the adjustments for systolic and blood pressure variability or other blood pressure parameters. In the second study, I want to highlight this prospective follow-up of 275 hypertensive patients with erectile dysfunction. There are epidemiological studies out showing that total testosterone is a cardiovascular risk predictor. In this study, it was focused on hypertensive patients with erectile dysfunction, and they were categorized according to the total testosterone level. Overall, clearly as indicated here in the Kaplan-Meier curves, those patients with a total testosterone below 4.0 nanogram per milliliter, the lowest tertile, these were the patients who had the highest incidence of major cardiovascular events in the follow-up. And most important, in the Cox regression analysis, this total testosterone concentration was identified as an independent determinant, independent of age, blood pressure values, metabolic profile, antihypertensive therapy, statins, and so on. So total testosterone is an independent marker in hypertensive patients with erectile dysfunction to indicate a higher cardiovascular risk. Finally, I want to address these prognostic data from a 3.5 years follow-up study, a single center study, but more than 2,000 patients including, dealing with the question whether treatment-resistant hypertension is a risk indicator. Well, of course, intuitively, we think that the higher the blood pressure is, the greater is the risk. But when you go to the literature and analyze whether there are any data out about the prognostic importance of treatment-resistant hypertension, there is only so far one small study published, and therefore I have chosen this trial where 18.4% had been identified having treatment-resistant hypertension, and their prognostic value was compared to those who don't have. Now, clearly overall, the composite outpoint, and as one assumes that patients with treatment-resistant hypertension had a by far higher rate cardiovascular complication rate. This holds also true for some composites such as atrial fibrillation, stroke, coronary artery disease. And the diagnosis of treatment-resistant hypertension emerged to be independent as a predictor of composite cardiovascular endpoints, independent of age, male gender, and smoking. Let's move forward to therapeutic options. For a couple of years, we have now the interventional therapy of hypertension, in particular of treatment-resistant hypertension, by applying renal denervation. And there have been some new follow-up data for this method I want to highlight. First of all, we have an 18-month follow-up of the Simplicity Hypertension 2 trial, which was a randomized trial, and the original 6-month follow-up has been published in The Lancet 2 years ago. It was seen that immediate renal denervation led to a substantial fall in blood pressure after 6 months. In the control group, there was no change or even an increase. Now, this has been published. Those patients who had been on the waiting group were asked whether they want to have, after 6 months, renal denervation, and 37 agreed. And as you can see here, also in this waiting or control group, those who had renal denervation, there was a substantial fall in blood pressure after 6 months, and also in the long-term follow-up of 18 months. Now let's analyze these data a little bit different and look at the blood pressure fall of the immediately treated patient group, the RDN group, and the crossover group who had the renal denervation after 6 months of waiting. As you can see here, and this is a message, the blood pressure fall was between 25/72 mmHg in systolic terms and between 10 and 12 mmHg in diastolic blood pressure. One important thing is also we see a sustained blood pressure response. There is no attenuation so far until 8 months. Therefore, there is no signal of a reinnervation, which is of functional importance, and therefore extends our knowledge about the blood pressure reduction after renal denervation. Now, these data here, what you see here, have been relying on office blood pressure measurements. What about ambulatory blood pressure monitoring? There have been a single center study with 80 patients with treatment-resistant hypertension, followed up for 6 months. You can see here the characteristics. I think they are quite impressive. A blood pressure 169/92, while on 5.4 antihypertensive medications on average. And you can see again a very nice blood pressure fall in terms of office blood pressure reduction by 26/9 mmHg, which fits into the range I just have shown you. What about the fall in ambulatory blood pressure monitoring? On average, there was a fall in the mean 24-hour blood pressure by 12/7 mmHg. You see here the pre-treatment blood pressure values, but this needs a comment. If you compare in pharmacological studies where office blood pressure and ambulatory blood pressure monitoring has been compared, you always see that approximately only 50% of the blood pressure fall, let's say of the numerical blood pressure fall, is then evidenced by 24-hour ambulatory blood pressure monitoring. So there is no surprise that the fall in ambulatory blood pressure monitoring is less than by office blood pressure monitoring. This is also observed in all pharmacological trials. Nicely to see also that not only the daytime blood pressure but also the nighttime blood pressure, which I stressed just a couple of minutes ago, was nicely controlled by 10/5 milliliter mercury after renal denervation. I feel it's important to stress that these patients with treatment-resistant hypertension with an average of 5 medications or more, they usually have a higher level of anxiety, depression, and their quality of life is impaired. Now, what happens to these parameters after renal denervation? This is analysis carried out in more than 170 patients with treatment-resistant hypertension, and it's indicated here, quality of life improved significantly. The discomfort and a clinical sign headache improved as well, highly significantly. But the most important thing for me was that the anxiety level and depression level was significantly improved after renal denervation in parallel to the reduction in blood pressure. And this occurred in particular in those patients who had a clinically relevant anxiety level at the beginning. It was 21%, or clinically relevant depression right at the beginning, 17%. So quality of life, anxiety, and depression level improved after renal denervation according to this first data carried out in a large population of more than 170 patients after renal denervation. What about novel pharmacological compounds to treat hypertension? Well, this is really a disappointing field. There are no new compounds on the horizons that will be developed for antihypertensive treatment. The reason for that is that there are new compounds, but they will more developed in the field of protection of the cardiorenal syndrome and not for the reduction of blood pressure, although they work by means of blood pressure reduction. You will later hear about the Paramount study, for example. However, there are some anti-diabetic studies that have, let's say, as a side effect, a reduction in blood pressure. One of the new classes of anti-diabetics are the so-called SGLT2 inhibitors that inhibit the uptake of glucose in the proximal tubular cell. And at the same time also, to some extent, sodium reuptake is reduced. And these patients, after receiving this anti-diabetic therapy, lose also weight. So enough arguments to have a closer look at the antihypertensive effect of this anti-diabetic new drug class. First of all, I want to share with you these data of a pooled analysis of studies done for registry purposes, 12 placebo-controlled trial, phase 2b and 3 studies, and here are the results. Blood pressure was captured as a safety measure, not as an efficacy measure in these studies. And as you can see here, this compound dapagliflozin reduced blood pressure by -4/2 milliliter mercury. In another trial, this antihypertensive effect of dapagliflozin was addressed more rigorously. First of all, a randomized placebo-controlled double-blind trial design has been chosen, and second, 24-hour ambulatory blood pressure monitoring was used to assess the antihypertensive effects. All these diabetic patients had a somewhat elevated blood pressure and were on a RAS blocker. As you can see here, no change with placebo, a fall by hydrochlorothiazide 25 milligrams per day by 6.6 milliliter mercury, and dapagliflozin was half of this effect. But most interestingly, if you separate day and nighttime blood pressure, dapagliflozin lowered blood pressure significantly only throughout the daytime, not at all at nighttime. And of course this makes sense, because this action is dependent on hyperglycemia, and if you do, and usually you are not eating during night, and therefore you have also no mode of action and no antihypertensive effect. Thank you very much for listening to these highlights in the field of hypertension.
Thank you very much, Roland. Now we move forward to imaging, and Pepe Zamorano is going to present this.
Dear colleagues, thank you, Keith. I'm extremely delighted to be with you here and honored just to get all the imaging for the highlight session. In fact, we've seen several reports during the ESC Congress just highlighting why imaging is important in the clinical decision making. Well, difficult to summarize, but I have picked the important data coming from echocardiography, adding diagnostic value and prognostic value in the field of mitral regurgitation, and also what is new, how to assess diagnosis, or how to better assess diagnosis and prognosis of aortic stenosis. From the CT, I think is the question how to better select patients for TAVI, and also adding prognosis in patients with cardiomyopathies, much more or beyond the coronary arteries. From the MRI, I think that a stress MRI is going to play a role in better deciding what to do with our ischemic patients, and, well, assessment of LV mechanics with 3D echo for sure will be a next step in assessing necrotic tissue. Let me start with the echo. And this nice report coming from Belgium was to assess the use, or how to better assess functional mitral regurgitation with echocardiography. We don't really know, still don't know what to do with patients with functional mitral regurgitation. Well, operating these patients is difficult, also medical treatment is difficult, and also we don't know how to better assess the diagnosis of such patients. The aim of this study was to test the value of the three-dimensional echo-derived vena contracta area to quantify functional mitral regurgitation at rest and during exercise. And in fact, what are the parameters that better predicts severe functional mitral regurgitation during exercise? As you can see in this slide, the 3D vena contracta, both area and length, is the best predictor to assess the severity not only at rest, but also to predict what will happen during exercise in terms of the severity of mitral regurgitation. Here you can see a couple of examples how to analyze with the PISA method at rest with 2D and 3D during exercise, and how easily you can see the vena contracta in the 3 dimensions with transthoracic echocardiography. In fact, these authors conclude that the presence of a relatively large ellipsoid vena contracta at rest may be a marker of severe dynamic functional mitral regurgitation, despite the grading of functional mitral regurgitation as mild initially. So in fact, you change or you predict better the severity of the mitral regurgitation. Thus, the assessment of vena contracta area is highly sensitive to tract exercise-induced changes in ERO, while the PISA method shows lower sensitivity. What is new in aortic stenosis, nicely assessed by Julien Magnier, and I think that there are 2 important issues that may change our strategy in the near future while assessing aortic stenosis. First, valvular arterial impedance, and secondly, analyzing the pulmonary hypertension while exercise in these patients. Well, we know that in aortic stenosis, the valvular arterial impedance represents the cost in millimeters of mercury for each systemic ml of blood, indexed for body size pumped by left ventricle during systole. And here you can see that the left ventricular afterload in aortic stenosis is decomposed by the valvular load plus the arterial load. Well, is this important, or should we assess the valvular arterial impedance in our patients with aortic stenosis? Well, it's clearly demonstrated here that the ZVA is really related to the maximal exercise capacity, and in fact it will be a new marker of severity in aortic stenosis and functional capacity in our patients. Here you can see that the analyzing during exercise test the pulmonary pressure is important, and in fact is a prognostic marker. This has been, will for sure be incorporated in the labs while assessing what is the prognosis of such patients and in order to select the best therapy. You can see that the presence or the development of exercise-induced pulmonary hypertension implies a worse prognosis in our patients. CT is going to play a more important role in selecting patients for TAVI. This report during the ESC Congress, the aim of the study was to compare the measurement of the aortic annulus area by CT scan versus the estimation by both transthoracic and transesophageal echocardiography, and in fact to assess which method is better to predict the paravalvular regurgitation after TAVI. We know how easily can be the diameter seen with CT. There are some more problems while assessing the LVOT, the left ventricular outflow tract, the annulus diameter with echocardiography, but this group, what they state are the different scenarios between the concordance of the annulus measurements or the prosthesis mismatch by CT and echo, and they conclude that in fact, this study concludes that the lack of congruence between prosthesis and annulus size is really the marker or what is really associated with paravalvular regurgitation after TAVI. The better tool is CT. CT is a better tool for detecting the mismatch between prosthesis area and aortic annulus area, and what is more important, for predicting the paravalvular regurgitation as compared with transthoracic echo or transesophageal echo. Therefore, the CT-based approach may be a reliable method to select the appropriate size for TAVI, and in this regard, there is no doubt that a specific CT-based sizing recommendation should be developed. But it's not only CT an important tool to analyze morphology, it's also prognosis. And in this regard, this report coming from Japan showed that the information for the non-ischemic or in cardiomyopathies is not only assessing if the patient has ischemia or has coronary disease or not. In fact, this study aims to identify a specific organized substrates of ventricular fibrillation compared using a 320 CT slide and in non-ischemic subjects who had ventricular fibrillation with those who had sustained and non-sustained ventricular tachycardia. And there are two important patterns. The first one that can be seen here and pointed out with the arrows are the typical images of myocardial fibrosis seen with CT scan. And the second pattern is the typical, again pointed with arrows, myocardial fatigue change that can be detected with CT scan. Is this important? In fact, it is. And you can see here the comparison of the frequency of myocardial fibrosis and fatigue change on the CT pattern among the three non-ischemic arrhythmia groups: patients with ventricular fibrillation, patients with sustained ventricular tachycardia, and non-sustained ventricular tachycardia. Relevant to say is that in non-ischemic subjects, myocardial fibrosis may be a substrate of ventricular fibrillation, and fatigue change may be substrate of sustained ventricular tachycardia. It's really relevant that CT scan not only provides the morphology of the artery, but also the prognostic information looking to the tissue. Finally, a couple of reports coming from the very interesting reports coming from the MRI field. The first one is if MRI is going to impact in the decision making of patients with ischemic disease that will undergo coronary angiography. And this is coming from Deutschland, cardiovascular risk profile in the long-term survival and stress cardiac magnetic resonance imaging guided catheterization. We have here the two approaches. One is the conventional one in similar groups, risk groups. You can see the conventional approach based on exercise testing, conventional clinical history, and the other approach that is based in the results of a stress cardiac MR. And you can see here that, in fact, cardiac magnetic resonance imaging prior to coronary angiography was significantly more effective in terms of death and hospitalization than cardiac angiography based only in clinical findings, history, and exercise ECG. Finally, my last selection for this highlight session is, I think, a new hope for 3D speckle tracking echocardiography compared with magnetic resonance. We know that magnetic resonance is the gold standard in the detection of necrotic tissue. The aim of this study was to assess if LV mechanics, in fact, with 3D analysis enables an accurate and objective assessment of necrosis transmural after STEMI in comparison with the gold standard that is CMR. You can see that with the echo we can assess the 2D, the 3D motion score, but also the LV mechanics in a more deep way. And again, with CMR, as usual, we can detect necrotic tissue with the late enhancement in gadolinium. Here you can see the rock curves with the different LV mechanics parameters. And what is really interesting is that 3D strain parameters and 2D longitudinal strain had a good accuracy to identify segments with transmural necrosis when compared with the gold standard that is magnetic resonance. Significant differences were found between 2D and 3D longitudinal strain, being the former having a higher accuracy to identify transmural necrosis. However, while motion segmental analysis by experienced readers on good quality 3D data set was found to be superior than wall motion analysis in 2D images and than strain quantification for the identification of segments with transmural necrosis. Thank you very much. So in fact, if I may summarize, sorry for that, the message is echo new parameters, no doubt, for assessing diagnosis and prognosis. CT, better technique or the best tool for taking the TAVI decision in selection of candidates, but also adding prognosis. And finally, MRI, don't forget, stress MRI for better selection for coronary angiography, and 3D echo as an alternative for necrosis detection. Thank you.
Thank you, Pepe. Next on the agenda is Dr. Hendricks from Leipzig, who will report on arrhythmias.
Mr. Chairman, dear colleagues, ladies and gentlemen, exciting new technologies and interesting new study data have been presented here during this marvelous Congress in Munich from the field of arrhythmias and interventional electrophysiology. And I would like to share what I consider the most interesting of what we have heard over the last couple of days. We will take a quick look to the AF guideline update and then move to novel technologies to support catheter ablation procedures with particular reference to catheter ablation of atrial fibrillation and ventricular tachycardia. We will move on to an update of huge clinical studies on CRT, the reverse study with 5-year follow-up. We'll take a look to the Aristotle trial with particular reference to patients with impaired renal function, and take a look to very interesting data from randomized study on surgical ablation of atrial fibrillation. And if we have a minute left, we may go to one abstract that I consider particularly interesting. It would be beyond the scope of this highlight session to go into the details of the 2012 update guidelines on atrial fibrillation. After the 2010 milestone guidelines on atrial fibrillation, there is now an update with particular reference to the use of novel oral anticoagulation drugs to prevent stroke and bleeding. There are interesting and very valuable new information on the application of antiarrhythmic drugs, particularly dronedarone. There are new important study data that have been implemented by John Kamm and colleagues into the guidelines, and the introduction of vanacalant for cardioversion, pharmacologic cardioversion. For the first time ever, these guidelines focus on the use of left atrial appendage occlusion devices and guide handling in the field. In addition, surgical excision or occlusion of the left atrial appendage to prevent stroke is mentioned and worked on. And last not least, there are new recommendations from the field of catheter ablation of atrial fibrillation, where the class 1 indication, level of evidence A for paroxysmal atrial fibrillation after drug failure, and also an updated indication for atrial fibrillation in paroxysmal atrial fibrillation ablation as primary indication in selected patients. So my recommendation really is take a look to these new guidelines as the ESC website. Now we will do a flashlight view on new technologies which have been introduced to the field of arrhythmias and interventional electrophysiology. A new chapter has been opened in interventional electrophysiology with the application of MRI technology as an interventional suite. Two centers have introduced the use of MRI interventional suites for diagnostic and therapeutic cases performing successfully catheter ablation of atrial flutter within an MRI environment. I consider this particularly interesting and future-looking. You see here one of these studies, the right ventricle, the right atrium, the ablation catheter, which is placed at the tricuspid annulus and then withdrawn back to the inferior caval vein. And proof of concept is there. It is feasible to work in this environment. Mapping of focal sources for atrial fibrillation and rotors in the clinical setting. We know from animal experimental studies and detailed optical mapping that rotors may play a role in the pathophysiology of perpetuation of atrial fibrillation. For the first time, this has been now shown in the clinical setting with the technique of firm mapping and ablation. With a basket catheter, signals are generated and processed in order to visualize these rotors. And surprisingly to me, it was possible to ablate even persistent atrial fibrillation with a pinpoint focal lesion as shown on this slide. Preliminary clinical data, randomized data, indicate that this new technology may add on the efficiency for catheter ablation of atrial fibrillation. As this slide shows you the results of firm mapping supported catheter ablation in comparison to non-firm guided ablation procedures. Use of new imaging technologies to support catheter ablation. Paolo Della Bella from Milano, one of the hugest labs in Europe working on ablation of ventricular tachycardia, beneficially showed that imaging truly supports catheter ablation of ventricular tachycardia, as he could show that with MRI technology, fibrosis can be visualized, and these data can be implemented and used in the electrophysiological working station in order to develop a treatment strategy in settings that were very difficult to tackle without this information. In addition, Della Bella and colleagues showed that new endpoints for catheter ablation of ventricular tachycardia aiming on the complete elimination of late ventricular activations and late potentials as depicted on the right side of the slide may be very helpful to improve the outcome and reduce recurrence rate. As depicted here, these are more than 300 patients. The recurrence rate with complete ablation of late potentials was significantly lower as compared to a non-inducible endpoint taken for the ablation procedure. All this looks very promising. Randomized clinical trials in the field of arrhythmias and interventional electrophysiology. We had the privilege to receive the 5-year follow-up data of the Milestone Reverse trial, aiming on the effects of CRT, cardiac resynchronization, in patients with clinically mild heart failure. Cecilia Linde has reported previously the 1-year and 2-year results. The 5-year results shared with us here in Munich clearly showed that the reversed remodeling induced by CRT sustains over 5 years, and that's good news for the treatment of heart failure in patients with an indication for cardiac resynchronization. So the take-home message from this trial is the beneficial effects of CRT on left ventricular remodeling sustain over 5 years. Taking a look to the field of novel oral anticoagulations and atrial fibrillation. The Aristotle trial has been published, clearly showing that apixaban 5 milligrams twice daily outperformed treatment with warfarin. Stefan Hohenloser presented here in Munich a novel analysis of the data with particular focus on patients with impaired renal functions, because we know that patients with impaired renal functions not only have a higher stroke rate as compared to patients with normal renal function, but also have a significantly higher bleeding rate. For the interpretation of the data of this study, it is important to note that patients with significantly impaired renal function have been excluded from the Aristotle trial. These are the key data and information from that sub-analysis. On the left side, you see stroke and systemic embolism and the event rate within 1 year under warfarin as the blue graph with a confidence interval, and under apixaban. And as you can see, there is a difference in stroke and systemic embolism in patients with significantly impaired renal function, while there was not that much of a difference when renal function was less significantly impaired. However, a significant difference was observed between warfarin and apixaban when it came to major bleeding, and apixaban clearly and significantly outperformed warfarin. Take-home messages: in patients with impaired renal function, apixaban is superior to warfarin with respect to the risk of major bleeding, and it seems that the benefit is greater in patients with advanced renal impairment. The last study I would like to share with you is particularly interesting because this study is so close to the clinical setting. Widimski and colleagues shared with us results on 224 patients that were scheduled for valvular or coronary surgery. All patients had documented atrial fibrillation, and these patients were randomized to undergo intraoperative ablation of atrial fibrillation regardless of any symptoms, selected as they came, randomly assigned. Primary endpoint of that study was freedom from atrial fibrillation or documented sinus rhythm at 12 months with a single 24-hour ECG, which is one of the limitations of this study. Here comes the rhythm outcome of that study with some surprises. If we take a look to the group, to the total group, we see a significant difference in favor of the ablation procedure. However, if we look into the subclasses of atrial fibrillation, there was no difference in patients with paroxysmal atrial fibrillation. There was no difference in patients with persistent atrial fibrillation. So all the benefits gained with respect to rhythm outcome was due to more sinus rhythm in patients with long-standing persistent atrial fibrillation. Very surprising, since this contradicts previous findings in the field of catheter ablation and surgical ablation as well. Looking to the secondary outcome parameters, another surprise, because although there was an improved rhythm outcome, this did not translate in a significant change in these secondary outcome parameters. Not powered for mortality, needless to say, but still, no difference. Major bleeding, no difference. Stroke, no difference, which is particularly surprising because left atrial appendage excision was performed in the ablated patients. No difference in the hospitalization for heart failure. My conclusion of that study is that surgical ablation of atrial fibrillation should be cautiously indicated in asymptomatic patients scheduled for cardiac surgery. Thank you very much for your attention.
The next presentation will be given by Dr. Verheugt from Amsterdam on acute coronary syndromes.
Thank you, chairpersons, for inviting me to give you the highlights on acute coronary syndromes during this Congress. Oops.
Just hit the escape.
Yeah. Escape. Okay. These are my disclosures. I will discuss with you three important points here with the acute coronary syndromes as of now. The new ESC guidelines, which are presented and released and published. Prasugrel in patients with non-ST elevation acute coronary syndromes who are managed conservatively in the first place, the Trilogy trial. And the third trial that was done in patients on warfarin undergoing coronary stenting, where they were randomized to triple antithrombotic therapy or dual antithrombotic therapy. But first, the guidelines. I think we must be very happy with the updated STEMI guidelines as published and presented on this Congress on STEMI. For me, the most important part of that is the update on STEMI networks, which are so very important to shorten the delay of treatment, primary PCI mainly, in patients who present at home or in the ambulance with a STEMI. Second, very important, it's not a guideline but a consensus document, is on the universal definition of myocardial infarction. It's the third definition, and for me the three most important points there were that there is a new definition of peri-procedural MI. The threshold has been changed. I think it's very important for studies but also for clinical management. Second, the high sensitivity troponins have been introduced into the definition of myocardial infarction. And third, by doing that, the diagnosis of unstable angina has disappeared, because if a patient presenting with chest pain has no elevation of high sensitive troponin anyway, then probably the patient has no coronary disease but other conditions that cause chest pain. But now the studies. I think the most important study on the management of ACS was the Trilogy study as presented in hotline number 1. We know about Prasugrel that it is registered for the use of PCI in patients admitted with all forms of acute coronary syndrome, STEMI or non-STEMI. Little or nothing is known how the drug behaves in patients who are treated conservatively. Of course, STEMI patients should undergo reperfusion therapy, but non-STEMI patients should go to the cath lab, but very often this is not done for several reasons, which I not discuss. 7,243 patients who were admitted with non-ST elevation ACS, either unstable angina or non-STEMI, were randomized to standard of care clopidogrel or to Prasugrel, although they are not managed invasively. And the majority of patients were given clopidogrel already at hospital admission, and in about 4 days after hospital admission the final decision was made not to go to the cath lab but go for a medical management, and those patients were randomized to clopidogrel as standard of care or Prasugrel. They were not loaded because they were preloaded with clopidogrel, and they were given maintenance dose of 10 milligram as used in the intervene patients, but only in patients with a low body weight were given 5 milligrams of Prasugrel. Patients with a stroke were excluded from the trial, and the presentation of the data of the 75 plus patients will be later done this year in Canada. A very small number of patients were clopidogrel naive and were early randomized because an early decision was made for a medical management, and they were loaded with clopidogrel and followed with standard therapy, or loaded blindly randomized to Prasugrel loading dose, and again 5 or 10 milligrams daily dose, 10 milligrams for the majority of patients and 5 for the low body weight patients. The duration of the trial was a maximum of 30 months, a minimum of 6 months, and the mean duration was 15 months. And as usual in these trials, primary endpoint was CV death, MI and stroke. This is the outcome of the study. It's completely flat. With regard to efficacy, there is no benefit whatsoever in patients managed medically for Prasugrel when compared to standard of care clopidogrel. There is some diversion of the curves after 1 year, but an interaction analysis didn't show a statistically significant interaction between the results before 1 year follow-up compared to that after 1 year follow-up. TIMI major bleed was increased as expected, but not significantly, but TIMI minor bleeding was significantly increased in this study. And it clearly showed that prasugrel should not be given to patients who have an initial strategy of medical management rather than an interventional invasive management. I think a very important finding which is currently online on the site of the New England Journal of Medicine. Second study I would like to show you is a study carried out in the Netherlands and Belgium in patients on oral anticoagulation for what reason whatsoever undergoing stent implantation. It's a big problem because these patients need to undergo triple therapy. Oral anticoagulation for stroke prevention or valve thrombosis, and antiplatelet therapy, dual antiplatelet therapy to protect their stents for thrombosis only for 1 month after bare metal stent and a year after death. And this kind of patients were randomized to the standard of care or to a similar strategy where aspirin was left out. Difficult to get it to the review boards, but we managed to do the trial. It was 1 year follow-up, and the primary endpoint was not an efficacy endpoint, it was a bleeding endpoint to get an impression about bleeding and the possible reduction by omitting aspirin. Secondary endpoints are given here, especially look at stent thrombosis, of course, and all individual components of the primary and secondary endpoints were also secondary endpoints. Here you see the results. As expected, there was a huge reduction in bleeding in 1 year if you omit aspirin at randomization. And you need to omit aspirin in only 4 patients to prevent 1 bleeding. I think a very positive outcome. And the reduction in bleeding was nearly 70%. What kind of TIMI classifications did we reduce by omitting aspirin? Here you see the previous slide, but now in numbers. There was a tendency to reduce TIMI major bleed numerically, but there was a significant reduction in TIMI minor bleed and TIMI minimal bleed. But I think that's an important reduction as well, because many doctors, especially in these patients, stop one of the treatments when patients develop TIMI minor or TIMI minimal bleeding. What were the locations of bleedings that were prevented? There was no decrease or increase in intracranial bleeding, nor was there a reduction in access site bleeding in these patients. But as expected, there was a strong reduction in GI bleeding when omitting aspirin. And the same was observed in skin bleeding. Now, what were the secondary endpoints of that study? There was no increase in stent thrombosis, and if any, there was a numerical decrease in stent thrombosis in the group of patients that in whom aspirin was omitted. There was no increase in stroke. There was a decrease in stroke, numerical decrease, but it was not statistically significant, nor was it for stent thrombosis. No change in target vessel revascularization in this high-risk population. There was no increase in myocardial infarction, and if any, there was numerically decrease in myocardial infarction by omitting aspirin. But most interesting and that unexpected, we saw a significant reduction in mortality, as pointed out here. And this is the Kaplan-Meier curve of the all-cause mortality. You see that there is a 60% reduction of all-cause mortality at 1 year by omitting aspirin, statistically significant, and you need to omit only aspirin in only 26 patients to save 1 life. Interesting study, which may be, of course it is not very big, but maybe the beginning of the end of aspirin in this high-risk group of patients on multiple antithrombotic therapies. So the take-home message, ladies and gentlemen, for the ESC 2012 with regard to ACS. There have been new guidelines on STEMI, important guidelines presented and published, important new definition of MI using the high-sensitive troponins presented and published. You should read it on the internet or in European Heart Journal. Third, prasugrel is not superior to clopidogrel in ACS patients treated non-invasively in the first place. And fourth, omitting aspirin in patients on warfarin undergoing stenting halves the risk of bleeding, does not influence stent thrombosis, and reduces mortality. Thank you very much.
Thank
Thank you very much, Freek. And now we move on to the next presentation, which is Interventional Cardiology, Kurt Huber.
Mr. Chairman, ladies and gentlemen, with respect to interventional cardiology, I selected the following subtopics: stents, primary PCI in STEMI, and interventions in valves. With respect to stents, I would like to present data from the PROTECT trial. This is a pragmatic trial. It compares Endeavor sirolimus-eluting stents with Cypher sirolimus-eluting stents with respect to definite or probable stent thrombosis at 3 years after PCI. And the background of this study is that due to different antiproliferative properties of both stents, it was expected to have a lower stent thrombosis rate in the sirolimus-eluting stent. This is the largest randomized controlled trial and also the first trial powered for comparing stent thrombosis with drug-eluting stents. It has been done in real-world patients with single and multiple coronary artery lesions, no limitations on number of lesions or vessels, and about 4,400 patients were randomized into the two groups. A 3-year follow-up with a first composite endpoint of definite or probable stent thrombosis, and 60-90% of patients could be followed in both groups over 3 years, so this is an excellent quality of this trial. It was expected to see 1.5% definite or probable stent thrombosis at 3 years with the sirolimus-eluting stent and 2.5% of problems with the Cypher stent. Indeed, the results were a bit better than expected, 1.4% stent thrombosis with the Endeavor stent, 1.8% with the Cypher stent, and between the two groups there was no statistical difference. You can see this also on these figures. So over 3 years, no difference. This was the primary endpoint. If you, however, do a landmark analysis starting with a measurement after 1 year, then you can clearly see that there is an ongoing increase of stent thrombosis with the Cypher stent, while this was not the case with the Endeavor stent. But this was not the primary endpoint, but it's just an important secondary finding. In another trial, the socioeconomic status and outcome after PCI was investigated. An observational registry in more than 13,000 consecutive patients undergoing PCI after acute coronary syndromes. The socioeconomic status was assigned to each patient according to 5 quintiles of deprivation, with the quintile 1 as the least deprived situation and the quintile 5 as the most deprived situation. Follow-up was done for a median of 3.7 years. And here the interesting outcome. So with respect to a log-rank testing, there was a highly statistically high significant advantage of patients in the lower quintiles compared to patients in the highest quintile, where all-cause mortality also was highest with respect to the follow-up time. Another interesting trial investigated the change of lifestyle after PCI, respectively what patients know about the need of change of lifestyle. This is a patient-based audit of current information practice. Questionnaires have been used with 40 questions each, and 1,800 patients were investigated at 29 both interventional and non-interventional centers. So an unselected consecutive post-PCI population was here investigated in Swedish hospitals. So these are interesting data, because about 10% of patients after 8 weeks of the acute event said that they didn't get any information about how they should change their lifestyle. Patients who knew that they have coronary artery disease and should change their lifestyle were in a range of about 20 to 30%, with slight differences between men and women. But patients who believed they were completely healthy and had not to change their lifestyle were in a range of 30 to 40%. And also patients who believe they're healthy but have to change their lifestyle were in the range of 20 to 30%. So I think it's quite interesting to see this data. My take-home message with respect to stents is that the second generation Endeavour drug-eluting stent did not fulfill the expectations of a significantly lower definite or probable stent thrombosis rate after 3 years versus the Cypher stent. But to find potential statistical and clinically important differences between old and new generation drug-eluting stents, a longer follow-up time might be useful. On the other hand, and this is my personal opinion, with the use of newer generation drug-eluting stents with extremely low stent thrombosis rates, the hypothesis behind the projectile is no more this relevant. Socioeconomic status, but also lack of power in rehabilitation programs to change the attitude of patients towards a healthier lifestyle hinder optimal care after PCI. With respect to primary PCI in STEMI, I would like to focus your attention on the FAST-MI registry. The data I am presenting is STEMI patients only, and about 6,700 patients of 4 surveys have been investigated in 5 years time intervals. So a very interesting finding was that risk factors, for example, current smoking, but also metabolic risk factors, increased over time, over the last years, which was especially the case for younger women. What was positive in this investigation over years was that there is a change in patient behaviors. For example, the time from onset to first call, onset of pain to first call or contact with a physician decreased from 2 hours to 74 minutes within 10 years. The direct call into an infarction network and the direct transportation of patients to a PCI-capable center increased from 20 to almost 50% during that time span. And there was also a stepwise optimization of peri- and post-procedural agents over time according to guidelines. So beta blockers, ACE inhibitors, antiplatelet agents, anticoagulants, and statins were used according to the guidelines, and this is a very important finding also. With respect to the reperfusion strategy in STEMI patients, an increase of primary PCI from 10 to more than 60% could be detected, and at the same time there was a decrease of patients receiving thrombolysis, the blue bars, and also of patients who did not receive any reperfusion from 50 to 25%. This turned out to show a clear reduction in 30-day mortality over time from 11 to 13 down to 4%. And this is also true if you correct by statistical methods, if you adjust for risk with a multivariable analysis and risk factors with age, sex, body mass index, previous history, and the use and type of reperfusion therapy. If you offer to your patients reperfusion therapy and you do it in the correct patient cohorts, you are able to reduce mortality down to 2 to 3% in your STEMI patients. Another important trial is the IABP Shock 2 trial. This is a randomized comparison of intra-aortic balloon counterpulsation versus optimal medical therapy in addition to early primary PCI in acute myocardial infarction complicated by cardiogenic shock. 300 patients were randomized into each group, and the follow-up was 12 months. So these are the somewhat unexpected results that show still a 40% mortality rate after 30 days for both groups, controls, which only received primary PCI, and also patients who received, in addition, intra-aortic balloon pulsation. The take-home message here is that there's an increase of cardiovascular risk factors over time, especially in women. But the implementation of guidelines for revascularization of patients with STEMI, this is network organization, increase of primary PCI, decrease of fibrinolytic therapy, but if you use it, an increase of pre-hospital fibrinolysis, and the optimization of pharmacologic therapy has decreased overall mortality over time from 11 down to 4%. Intra-aortic balloon pulsation offered routinely to STEMI patients in shock referred for primary PCI seems to be safe, but it is without additional benefit on the clinical outcome. With respect to interventions on valves, I would like to show you the Access Europe registry, a post-market study of the MitraClip system for the treatment of significant mitral regurgitation in Europe. This is an analysis of outcomes at 1 year. And of the 567 patients included, there was a 99.6% procedural success rate, so very high. About 60% of patients received one MitraClip, about 37% needed a second one, and in a low number of patients, 3 or 4 clips were necessary. As expected, the Kaplan-Meier curve showing freedom from death was better in patients who had a lower Euroscore compared to patients who had a higher Euroscore when they received this specific treatment. With respect to mitral regurgitation grade, there was a clear decrease of mitral regurgitation, which was in the majority of patients at baseline 3 or 4, to 1 and 2, and about 80% of these patients had this very favorable result still after 1 year. And this went in parallel with an improvement of the NIHA functional class. The German Aortic Valve Registry is a nationwide complete survey of patients, more than 30,000 patients with severe aortic stenosis undergoing either surgical aortic valve repair with or without bypass surgery at the same time, or transfemoral or transapical TAVI. This is a prospective, controlled and multi-center investigation, and the follow-up was planned for in-hospital after 30 days as well as after 1, 3 and 5 years, and I give you the data for in-hospital outcomes. From the more than 30,000 patients, about 6,500 patients were treated with surgery, without bypass surgery. About 3,500 patients had surgery with bypass surgery, 2,700 patients transfemoral TAVI, and 1,200 patients transapical TAVI. Patients which were selected for TAVI had clearly higher risk, and they were older, more female, and had higher rates of heart failure, left ventricular ejection function below 30%, atrial fibrillation, pulmonary hypertension, COPD, and there were more diabetics in this group compared to surgically treated patients with aortic stenosis. And these are the outcome data with respect to in-hospital mortality, showing that there is no statistical difference between patients receiving aortic surgery or transvascular transfemoral TAVI. There was a slightly increased mortality for transapical TAVI. And at the same time, the feared operative or peri-interventional events like cerebrovascular events were about the same for all groups. The take-home message here is that mitral clipping is a feasible method in patients in which mitral valve surgery is not possible, and this method leads to an improved exercise tolerance and an improved quality of life. But further studies versus surgery are mandatory, especially to prove also the safety and real efficacy of this method. With respect to transfemoral TAVI, this seems to be as effective as aortic valve surgery, despite the higher risk profile of the patients and the higher periprocedural vascular complication rate. With this, I would like to stop my presentation. Thank you very much for your attention.
Thank you very much, Kurt. Our next speaker is Adam Torbiski from Poland, who will report on valvular heart diseases and pulmonary circulation.
Thank you very much. Thank you for the honor which I have to present this particular area. We do not have major controlled randomized trials here, but I hope you'll find some of the data which were presented, and also, even more importantly, ideas as deserving discussion, presentation, and maybe generating some new trials. I would like, however, to start with new ESC guidelines on valvular heart disease. which come 5 years after the previous edition. And why do they come? Because there is not only evidence accumulated on risk stratification, diagnostic methods, and therapeutic options, but there is also a place in this area for a hard team. And this has been nicely shown by the joint authorship of those guidelines, both produced by ESC and European Association of Cardiothoracic Surgeons. There is no place to discuss the details of those guidelines, but I would like to draw your attention to several messages which I find particularly important, especially in the era of aging patients with valvular heart disease. And the first issue is when you decide whether there is a need for intervention on the valve, to be sure that the symptoms that the patient presents are really related to valvular heart disease, that the expected benefits of intervention versus spontaneous outcome outweigh its risk, taking into account local resources and experience for this particular intervention, and finally, what are the patient's wishes. The guidelines call for consistency between echocardiographic data and the clinical presentation in symptomatic patients, and also call for stress testing in asymptomatic patients, and also ask for research in this area, because most of the recommendations are still Class C recommendations. So I would like to start with a trial, a very elegant trial, which just fits into this exercise testing in asymptomatic valve disease, in this case mitral valve regurgitation, coming from a joint effort of colleagues from Belgium, Liège, and Quebec in Canada, which nicely shown that the incidence of cardiac events in asymptomatic mitral valve regurgitation patients, and those events were mostly emerging symptoms of mitral valve regurgitation or increasing left ventricular systolic dysfunction, were correlated with the exercise level of BNP. As you can see on the left side of the slide, the tertiles were strongly related to the incidence of cardiac events, but even more importantly, the exercise BNP added precision to the prediction of those cardiac events. So taking BNP just 3 minutes following peak exercise is useful, and the conclusion is that these findings provide support for the systematic measurement of BNP at the time of exercise testing or exercise stress echocardiography in patients with some asymptomatic mitral valve regurgitation. Now this is a mini quiz for you, another type of valvular problem, in this case Enterococcus faecalis endocarditis. And the report comes from Denmark, and the question is, what did our colleagues change in their guidelines in 2007 in order to maintain the efficacy, but at the same time prevent their patients from the deterioration in kidney function, here measured by the decrease in eGFR? And the answer is very simple. They just stopped their treatment with gentamicin at 2 weeks instead of going according to our guidelines up to 4 to 6 weeks. There was a paper on this in 2002 from Sweden, but now we have evidence from the real life that this is feasible, safe, and not only maintains the efficacy in terms of survival, but also is not worse in terms of relapses of endocarditis. So maybe a message for the new guideline team working on endocarditis. But not all guidelines are successfully implemented, and here I have a slide which would probably suggest that we should include dentists in our heart teams, because they seem to be a little bit confused with application of the guidelines. This is the survey performed in Germany, actually 2 surveys, in 2003 in blue and in 2009 in pink, presented by colleagues from Boehm. You know that in 2007, AHA issued recommendations which in fact restricted the prophylaxis with antibiotics to very small number of indications in terms of cardiac disease. And in fact, what happened is that those recommendations were misunderstood by some of the dentists, and some highly dangerous lesions, such as congenital heart disease, in fact resulted in decreased application or prescription of antibiotics prior to high-risk dental procedures. On the other hand, some others, such as mitral valve prolapse, were considered congenital lesions, and the antibiotics were prescribed even more often. In any case, still 60% of patients with native heart disease were receiving antibiotic prophylaxis, which is not supported by evidence or by the guidelines. It is also important to see what is really followed by the dentist. Those are not guidelines, as you can see on the right-hand side, but the passports which the patient carries with him to the dentist. So please take attention to provide this type of information, individual information to the patients, because this apparently works much better. We don't know whether 2009 ESC guidelines were more successful, but the colleagues from Boehm performed these types of survey every several years. The first were done in 1980, so we'll probably learn during one of the next congresses. Now let's move to the fascinating area of sex. I think we can say today that we have regular sex or in vitro sex. And here you have very interesting data coming from Karolinska in Sweden, which sex is safer. And the data comes from a large cohort of women. Almost 25,000 women were submitted to in vitro fertilization, compared with over 100,000 matched mothers. And as you know, the most dangerous complication of pregnancy from the cardiovascular point of view is the episode of pulmonary embolism during pregnancy. Now, this trial looked at the added risk of venous thromboembolism and pulmonary hypertension beyond that which is normally found in pregnant women. You can see here the normal distribution of risk. The risk is slightly elevated, then more elevated during early postpartum period in normal pregnancies. And here on the upper level, despite really close matching of the two groups of mothers, there is a almost 5-fold increased incidence of venous thromboembolism, and it is up to 7-fold increased in the risk of pulmonary embolism. Now, the implication of this finding is very important. First of all, in pregnancy, diagnosis of pulmonary embolism is quite difficult, also because it implies needs in most of cases ionizing radiation methods that use this, and of course those mothers will be very reluctant to be submitted to this without apparent and important reasons. There is a case for maybe modification of the induction therapy, hormonal induction therapy, maybe even considering a primary prophylaxis in the first 3 months of pregnancy, which resulted from in vitro fertilization. Anyway, very important piece of information requiring awareness. Then a short note about the trial coming from the Italian Pulmonary Embolism Registry and reported by colleagues from Perugia about the significance of markers of right ventricular dysfunction and injury in relationship to in-hospital outcome in acute pulmonary embolism. And as you can see, they tried to look at the same thing that the 2008 PE guidelines of the ESC suggested in their prognostic assessment algorithm. So whether right ventricular dysfunction and injury was present and was present together, or one of those elements could be found. I will not go into the details of this trial, but just try to put it upon this scheme of the ESC, where you can see that the risk of the patient, the risk of dying early because of pulmonary embolism, is, if the patient has no hemodynamic disturbances, is related either to concomitant presence of right ventricular dysfunction and myocardial injury, or the presence of one of those risk markers. Whereas if both are absent, the risk is considered low. And on the right side, you see how well those algorithms, those prognostic algorithms, were matched to the real-life situation. So a good news for using the same type of approach in the next edition of the guidelines. Now something about chronic thromboembolic pulmonary hypertension. This is not frequent but very important consequence of some of the acute pulmonary embolism, namely the thrombotic lesions, the thrombi do not lyse, and as a result there is a progressive increase in pulmonary hypertension. This entity can be surgically treated, but many patients, about 50% of patients, have this stenosis so distally that they are impossible to approach by surgery. And our Japanese colleagues tried to approach this problem with pulmonary angioplasty. You can see that this is a very demanding procedure, 22 patients, but 250 lesions which should have been dilated. Sometimes this needed several steps because of elastic recoil. There were some complications, namely hemoptysis, but the effect on pulmonary artery pressure was very strong. And as you can see, also the survival, this is a pilot study, very small study, compared to historical controls, was quite encouraging. Please note that though those were historical controls, still the patients were hemodynamically very similar and quite severely ill. So this is a good message for patients who so far were no option patients with this disease, with chronic thromboembolic pulmonary hypertension. And this completes my report. Thank you very much.
The next presentation will be given by Dr. Anker, Heart Failure and Cardiomyopathies.
Thank you very much. I have the pleasure to show you the data that was presented at this meeting with regards to heart failure. Now, I'm delighted to show you some new information on our 2012 guideline. Had the pleasure of selecting several studies from the highlight session, from the late breaker session, and will share with you some information concerning safety concerns in heart failure. Now, at this meeting, the pocket guideline for the 2012 ESC HFA guideline on the treatment and diagnosis of heart failure became available. This pocket guideline is easy to use, fully recommended to be in your hands whenever you deal with heart failure patients, and it validates and shows to you that we now have a broadened selection of drugs to improve outcomes in heart failure patients, besides ACE inhibitors and beta blockers that should be used in all patients with systolic heart failure. Also, there is now in New York Heart Class 2 patients a 1A indication for eplerenone, and in addition, when patients remain symptomatic, have a low ejection fraction and have a high heart rate, ivabradine should be considered. The guidelines also clarify and modify the structural way we should use for diagnosing heart failure. This scheme will follow you in your educational programs for the next 4 years, I'm pretty sure. When you suspect heart failure, you distinguish between acute onset and non-acute onset. It is recognized that the medical systems in the world are different, and you may then choose primarily an assessment after some simple assessment with ECG, chest X-ray, and or clinical investigation. Then you may choose to use either an echocardiography primary approach or first a biomarker-based approach using natriuretic peptides to make the diagnosis of heart failure more or less likely, to then use echocardiography. The new further issue about this scheme is that we now have in acute onset heart failure not 2 natriuretic peptides to consider but 3. So besides BNP, anti-BNP, also mid-region pro-ANP, and I'm delighted to say after long deliberations, new cutoffs were suggested what to use to make a diagnosis of heart failure less likely and to use it as an exclusion criterion. Now, coming to therapy, the most interesting results presented here relate to 2 phase 2 studies in the disease called heart failure with preserved ejection fraction. First, the Paramount study using a drug called LZZ696. What is this? This is an angiotensin receptor neprilysin inhibitor. May still help you, not very much. Well, basically it's a fused drug with 2 components, one being valsartan, you know that, and one being a neprilysin inhibitor, which is a NEP inhibitor, neuroendopeptidase inhibitor, increasing BNP levels also. Now, that drug, when given to patients, in the body dissolves into its 2 components, and that is the reason why this study here in heart failure with preserved ejection fraction patients was done compared to the active comparator valsartan. 301 patients included, mean age 71, mostly in New York Heart Class 2, and because of an inclusion criterion that enforced that patients had to have at least an anti-BNP value of above 400 picogram per milliliter, the average level is about 830. These patients were rather well treated for cardiovascular drugs that are typically used in systolic heart failure, but most likely for hypertension or management of coronary artery disease. The primary endpoint was significantly met, which was the reduction of anti-BNP values at 12 weeks, 23% reduction, which is a strong signal for potential benefit. There was a follow-up that also included echocardiographic assessment to study whether there was cardiac remodeling and whether there were other findings. This drug reduces blood pressure in heart failure in a highly significant way, and by 36 weeks we also can see that there is a significant difference for the change in left atrial volume. Now, left atrial volume is by many viewed as an anatomical summary variable for diastolic function. Left atrial volume was significantly reduced with this new drug. There is in discussion whether or not this is moving forward in phase 3, and I'm sure you will hear more in the future. Second trial in the space of heart failure with preserved ejection fraction was the ALDO-DHF trial. This study was presented by Burkhard Pieske, and the primary endpoint, and there were actually 2 of them, number 1 is shown on the left, which is the change of the diastolic function measurement in echocardiography E to E prime, significantly reduced with spironolactone, and this drug was given for 12 months, double-blind placebo-controlled study. So first primary endpoint, positive. Second primary endpoint in this study was the change in peak VO2 assessed in an exercise test, and as you can see here with a p-value of 0.8, no difference between groups. Now, these patients were in many respects similar to the patients studied in the Paramount trial, but there was one big difference. There was a much lower inclusion BNP value, and so the average anti-BNP in these patients was only 165. about 5 times lower than the average seen in the Paramount study. This value of NT-BNP was also significantly reduced, even if that was only a small change. Left ventricular wall motion index also significantly improved. Now, is there all good news? No, there is not all good news. Also, we found on the left, not surprisingly, an increase in potassium values, but then even more concerning, an reduction in estimated GFR in patients treated with spironolactone, about 5 milliliter per minute average reduction in these patients compared to placebo-treated patients. Furthermore, 6-minute walk distance significantly was reduced when patients were treated with spironolactone, even if that is a small change of only 15 meters, it was significant. And interestingly, new onset or worsening of anemia was more frequently observed in these patients. Why this is, we don't know exactly. You know that the TopCat study is a big morbidity and mortality trial with spironolactone in such patients is ongoing, and it is studying heart outcome events. Coming to heart outcome events, this is an important report, additional data on the SHIFT study. Now, we have a typical primary endpoint in heart failure called cardiovascular mortality or heart failure hospitalization, studied as a composite and studied as a time to first event. This means a patient experiencing a cardiovascular death after a first hospitalization, that event is ignored. That means a second and third hospitalization, that event is ignored. So the argument is that the time to first event analysis no longer fully reflects the true burden of heart failure in a contemporary population. I'm showing you here some data on the number of events completely ignored in modern trials for the primary analysis, 40 to 50%. Now, the authors investigated whether, when taking into account these events, what is happening then? Avabradine reduced the total incidence of heart failure hospitalizations by 25%. And as you can see here, first, second, and third hospitalizations were all lowered. Of course, you need to experience a first hospitalization to have a second hospitalization, and you need to have a second one to have a third. So statistically, you need to really take these things into account. But in the future, studies will use these methodologies more often, and you will see this now repeatedly. And to show you the impact, when 1,000 patients were treated according to the protocol as done in SHIFT, and you use a time to first event analysis, 47 hospitalizations for heart failure are prevented, whereas are 93 in total. Now, a little add-on to the IRBP SHOCK 2 study that you've seen before. This is an updated meta-analysis on IRBP's treatment effects in patients with cardiogenic shock. The totality of evidence is now a hazard ratio of 0.98 with no benefit. Assist devices, no benefit. Several drugs, no benefit. Really, acute revascularization for the time being is the only intervention that seems to have some impact. You've seen the mortality is still high. We need to do something about this. New drugs are considered. This trial is not primarily done in heart failure, but is of strong interest to heart failure physicians because it uses a drug that is now tested in 2 major heart failure trials, aliskiren. This is a renin inhibitor. It was tested in type 2 diabetic patients with an impaired estimated glomerular filtration rate. So kidney dysfunction, and in these patients studied in the altitude trial, also 10% had heart failure. 8,500 patients were randomized 1-to-1, approximately 4 years of follow-up. There was a primary composite endpoint showing several variables, including cardiovascular death, kidney problems, etc., etc. No impact whatsoever. This treatment is neutral overall. Of concern are the trends for an increase in sudden death and for an increase in stroke. I can tell you that the heart failure trials continue. Of course, the DSMB of these trials is aware of everything, so we need to see how this is working out in heart failure itself, but it's of course of great interest to heart failure physicians. And in type 2 diabetes, certainly there is no indication for aliskiren. Lastly, I would like to inform you about a very interesting abstract from a Danish group based on a nationwide registry on something very interesting and human, leg cramps in heart failure patients. Now, very often quinine is prescribed, and what is happening regarding outcome is completely unknown. About 50,000 patients with ischemic heart disease, about 85,000 without, and they were with or without beta blockade therapy. To make it short, in patients with ischemic heart disease, whether they are on beta blockers or not, this therapy of leg cramps is associated with a higher total mortality. Do not use this drug. Try to manage leg cramps in different ways. At least one way is to check for vitamin D deficiency. Thank you very much.
Thank you very much, Stefan. Now we move, last but certainly not least, to preventive cardiology. Vivian Conrads.
Ladies and gentlemen, it's a privilege for me to present the data and the highlights on preventive cardiology. I have no disclosures. Although I know it's pure coincidence, it seems a bit strange that I will be addressing prevention as the last speaker, and it somehow reminds me of the fact how we are dealing with prevention nowadays. We are still introducing aggressive prevention, often too late once a disease has already developed. Now, to illustrate you, let me show you the results of a study that was undertaken in 12 European countries and looked at how primary care is dealing with lipid treatment. More than 7,000 patients were included in this study. They were older than 50 years. They had more than one risk factor. Their 10-year cardiovascular mortality rate was estimated with the use of the SCORE algorithm. Patients were classified as high risk if they had a score above 5 or if they were taking lipid-lowering drugs. They were at very high risk if they had a score above 10 or were diagnosed with diabetes. Now, from the guidelines, we know that patients should receive immediate lipid-lowering drugs if these thresholds for LDL cholesterol are not met. Let me show you the results. There should have been another table here, but let me just tell you that for those patients that were considered high risk and for those that were considered very high risk, 1/3 to 50% of the patients were actually not treated with lipid-lowering drugs. At the bottom of the slide, you can see that for those that were actually taking a statin, LDL levels were not controlled in 60% and in more than 80% for those at high risk and at very high risk. So I think there is still a large gap that we have to close. The prospective urban-rural epidemiology is very unique in its kind. It aims to look at the effect of societal influences that are depicted or are estimated by the gross domestic product, as well as the influence of a wealth index that is based on household asset corrected for GDP. During this Congress, Dr. Yusuf presented data on the effects of GDP and wealth index on cardiovascular risk factors. He concentrated on behavioral risk factors such as smoking, physical activity, and diet. Now, for the pure study, almost 154,000 subjects were included in 17 low, middle, and high-income countries. They were in between 30 and 75 years of age. Now, I'm going to present to you a snapshot of the results that were shown by Dr. Yusuf. I'm not going to show the relationship between GDP and risk factors, but I'm going to concentrate on wealth index. You can see that if patients get richer, or subjects get richer, they will increase their energy intake coming from total fat, and the same is true for meat intake. The reverse is seen for overall physical activity, which actually decreases with wealth. And this is largely explained by occupational-related overall physical activity. Now, last but not least, if you look at current smoking behavior, you can see that there is a decrease with higher wealth, at least for men, whereas the curve is rather flat for females, and this might be related to cultural issues. The authors conclude that macroeconomic, read GDP, but to a much greater extent, microeconomic factors, that is, wealth, has a major impact on health behavior. If we want to globalize cardiovascular health, we need to focus in poor on the availability of healthy food and quit smoking. In those that are rich, we need to increase physical activity, we need to decrease the intake of processed food, and we need to continue the smoking ban. Now, another presentation given by Dr. Diaz addresses information on hypertension, again taken from the PURE study. Hypertension for this study was defined as an average of 2 digital recordings above 140 over 19 millimeters of mercury, or self-reported and treated hypertension. Look at the figures. A prevalence of above 40% worldwide. Less than half of these patients were aware that they had hypertension. 40% of them were being treated, and only 13% had their blood pressure controlled. Awareness, treatment, and control were lower in rural communities, in communities with lower income, and those that had lower educational level. Now, these results reflect a major failure of the healthcare system, and action is needed. It might be simplistic to think that we can prevent cardiovascular disease by solely concentrating on the heart and the coronary arteries. Now, this is the reason why I included a study on stroke, a study on gross stress, a study on pericardial fat, and a study on obesity in childhood. The study entitled Impact of Resting Heart Rate on Mortality, Disability and Cognitive Decline in Patients After Ischemic Stroke was presented by Dr. Boehm during this Congress. Now, the authors had access to data of more than 20,000 patients after a first ischemic stroke that were enrolled in the PROFIS study. The question they wanted to address is whether baseline heart rate is related to cardiovascular outcome, and the primary endpoint was recurrent stroke. They also looked at the occurrence of cardiovascular and severe incidents, as well as mortality. A second important question is whether baseline heart rate is related to functional outcome after recurrent stroke, and this occurred in more than 1,600 patients out of the initial cohort. Let me concentrate first on functional outcome. At the top of the slide, you can see that after you have grouped your patients into quartiles with regard to heart rate, that there is a significant decline in independent functioning for those that are at highest heart rate. Looking at the cognitive status, and this is measured with the mini-mental state examination, a cutoff of below 24 indicating early dementia is used. What you see here is that the proportion of patients that actually had a score below 24 increased with increasing heart rate, and a judged cutoff of 70 beats per minute was chosen here. Now, these data are at least hypothesis generating, but they do concur with animal experiments in which it was shown that stress leads to larger infarct regions post-stroke, and that you can, by reducing heart rate, irrespective of blood pressure, reduce the area at risk. This brings me to the Great East Japan Earthquake Disaster and Cardiovascular Disease. This study was presented by Dr. Shimokawa. All of you will remember the disaster that hit the Miyagi Prefecture on March 11, 2011. Nearly 16,000 people were killed during the earthquake. The authors had information on diagnoses that were written on ambulance transport records and that were confirmed by physicians. They recorded these diagnoses during a period of 15 weeks in 2012 of course, March 11 was included in that time frame, and they compared the incidences of cardiovascular diseases as well as pneumonia to the records that were available for 3 years preceding 2011. This is a busy slide, but what it illustrates is that the earthquake, or following the earthquake, there was a steep increase in heart failure admissions for acute coronary stroke, coronary syndrome, for stroke, for cardiopulmonary arrest, as well as pneumonia. There was a steep decline immediately following the earthquake for acute coronary syndrome, whereas the decline was much more slower for heart failure and pneumonia. And of interest, after the occurrence of a large aftershock, there was a second peak for stroke and for cardiopulmonary arrest. These data suggest that physical and mental stress, as well as deprivation in its large definition, do have an impact on the occurrence of severe cardiovascular incidents. The data did not change if the investigators looked at age or gender. What was relevant, however, is that the incidence of pneumonia was significantly larger for those that lived by the coast compared to the inland, and this probably has to do with the tsunami that followed after the earthquake. Visceral fat, as well as pericardial fat, is no longer an innocent bystander. It produces hormones, it has a strong pro-inflammatory effect and releases cytokines, and in the vicinity of coronary arteries, this might be very interesting and important. In a sub-study, the Heinz-Nixdorf recall study, 4,093 subjects were included. They were free of disease, of cardiovascular disease at the study onset. In these patients, using non-contrast enhanced cardiac CT, pericardial fat was measured. And the question that was asked is whether pericardial fat would relate to incident fatal and non-fatal myocardial infarction. As you can see, for those who experienced events versus those who did not experience events, if you look at the distribution of pericardial fat, there is significant overlap. But nevertheless, after Cox regression analysis, you can see that the relation that was seen in unadjusted figures between pericardial fat and incidence myocardial infarction was kept after correction for age and gender, traditional risk factors, and even after calculating coronary artery calcium score. This brings me to the last study I would like to present to you. A part of the PEP family heart study, which included data on more than 11,000 children in the Nuremberg region. These investigators measured anthropometric demographic characteristics as well as laboratory risk factors in children between the age of 3 and 18 years. Of the initial group of more than 11,000 children, 900 and 500 were classified as being overweight or obese. At the bottom of this slide, you can see that with increasing body weight, there is an increased prevalence of hypertension, and there is a difference between girls and boys. No CVD risk factor was present in 80% of normal weight children. However, only 2% of the obese had no risk factor. If you look at it in a different way, you can see that the combination of more than 3 cardiovascular risk factors out of the 7 that were assessed, there was a significant increase, starting with normal children, only 2%, going to overweight, 35%, and those that were obese had more than 80% of a combination of more than 3 risk factors. Now, obese children are tomorrow's heart patients. The investigators concluded that we might be very optimistic in thinking that we can eradicate obesity in children. But it might be more interesting and more efficient if we concentrate on those patients that are overweight and that accumulate cardiovascular risk factors. Ladies and gentlemen, this is the icing on the cake. We have seen the official presentation of the 2012 European Guidelines on Cardiovascular Disease Prevention in Clinical Practice during this Congress. Now, Now, I'm not going into detail, but what is important is that it includes a chapter on how and where to address cardiovascular prevention. And finally, we have the recommendations that cardiovascular disease prevention should be incorporated in all of your lives. It should not be restricted to those that are adults. We should encourage cardiovascular prevention even prior to birth, and we should educate future parents. With this, I would like to end my presentation. Thank you very much.
So thank you very much, Vivienne. Before Professor KOMAJDA ends this symposium, I've been asked to draw your attention to Best of ESC Live. This is a live program which will go out in 1 week's time. It has an independent panel to discuss some key highlights from this Congress that have the potential to impact on your practice. So a live interactive program on the 6th of September. And now over to Professor KOMAJDA.
I would like to thank the colleagues who prepared this very nice highlight session, including their chairperson, Professor Keith Fox. I would like to reiterate my thanks and my congratulations to the departing Congress Program Committee chaired by Professor Michel Boehm. And it is now time to close Munich 2012. We look forward to welcoming you in Amsterdam next year. Thank you very much.